Great. Let me ask you, Dr. Smith, and we're getting some feedback from your microphone. Maybe you can turn it down a little bit. But thank you so much for that comment. And go to Dr. Puckrine. Dr. Puckrine, then you also focused on data collection. You said the data is not available. What do we need to do to make the data available? And what should our community's response be? What should public policy be towards data collection that will give us a chance to achieve the accountability goals, but also have them tailored to our actual experience, our being communities of color, the Black community?
Yeah, this is a conversation that the African American, Asian community vigorously engage in. We're in a very difficult time period in which, as we can all see, our economy is in trouble. There's a tremendous temptation to save costs at the expense of people. And I think healthcare is certainly one of those areas that is well targeted for cost containment. When you look at minority populations, the first thing you have to recognize is that the American healthcare system was really never designed to provide quality care to diverse populations, to people of varying backgrounds. And so there's a real need, clinical side, to get good research and science.
Let me interrupt you there. What do you mean by that? That's a fairly strong statement. The American medical system was not designed to serve people of color or diverse communities. What do you mean by that?
Well, when you look at the research data, just take cardiovascular disease. In the history of the United States, when you look at cardiovascular, now speaking of drug clinical trials, 3,500 African Americans in the history of this country have participated in cardiovascular drug clinical trials. That's a stunning number. And you can look across the landscape and you're going to see similar evidence. And what that means is that the basic science is not there. So when you implement programs like pay for performance, evidence-based medicine, you name it, you're having to generalize about the implication on minority populations. By the year 2020, 40% of the youth population is going to be minority. That we're going to be able to provide. We need to be able to make sure that we have the best health system for that population. That's a very important. We need to both demonstrate. Seem to think that access to care is the answer, not access to quality care. So what you see a lot from the Democratic side is a conversation about access, but not a conversation about quality. On the Republicans, you see a lot of conversation about quality, but you don't see a lot of conversation about access. So we need to make sure that what's being made available to our community is quality health care. So I think that's really the real beginning point here.
Let me thank you. Let me go to our local participants here and ask them to weigh in on the question, and in the process talk about your own practices. Let me begin with Stella Whitney West, who is the CEO of North Point Health and Wellness, a facility around the corner from where we are, and one of the beacons of service and advocates for health and service in our community. Stella Whitney West, let me ask you to weigh in on the conversation. What does the pay for performance question mean for you? And as you address that, I want you to take a minute to give our listeners and our guests background on your organization, the critical role it plays in our community.
Sure. Thank you, Al. I think, first of all, both of the guests, Dr. Smitherin and Dr. Puckrine, brought up some really good points. And one of the things that we've had this discussion at our clinic regarding pay for performance, and our medical director, one of the things that he has said, which is what I strongly believe, is that when you're talking about pay for performance, thank you, when you're talking about pay for performance in terms of providing additional incentives to providers, you leave out the most important ingredient, and that is the patient and the community. One of the things that is key for making change and seeing improvements in healthcare is with that patient, and then with that patient's family, and then within the community that that patient resides. So I think having any kind of discussion about pay for performance, rewarding providers for providing quality care, it needs to first to begin there. Also, I think one of the things that we've looked at North Point, and certainly Open Cities is our sister clinic, and we've been around for 41 years, the two of us. We see ourselves as really healthcare homes. And what that means is that we have developed a practice where the patient is the center of our practice, and that we make sure that we focus on that relationship with that patient, and the relationship that that patient has with their provider, and the relationship that our center has with the community. So our whole model is based on a community health center model. At North Point, like I said, we've been around for 41 years. We have a patient base of over 20,000, very diverse. About 54% of our patients are African American. Over 80% of our patients are people of color. And so we provide both medical, dental, behavioral health. We have community health workers, and what our community health workers do is that they make that bridge between the patient, the provider, excuse me, and the community. So I think that's the important part that needs to be included in the discussion.
During Ebola, let me ask you to jump in here too and sort of explain the proposition from the point of view of your experience leading St. Paul's Open Cities Health Center.
I agree with, well, first of all, thank you, Al, for inviting me. And I do agree with Stella on the points that she talked about. The patient has to be the center here. It's just amazing how we continue to reward doctors for behaviors, bad or good. And that's what this is about, rewarding the doctor or the practice versus rewarding the patient. And how can we support the patient to better manage their health and to better take charge of their health? Because it's their health, it's their life. It affects their family, it affects their community. I brought with me in preparation for today literature that I just received at the end of the year about pay for performance from the various insurance carriers that our patients are members of from those plans. And it's interesting when they tell you how much money you could have gotten. Like, please, just give me the money. But for work that we're already doing. And exactly what the one doctor said, I'm not sure which one it was, but that talked about data collection. It's all about, a lot about that data collection. How did you get this information to say that we didn't really do all these things when I know that that's what we're doing? And we are in the process of converting from paper to electronic. So it's very challenging right now for us to produce data. Some data is still housed in the paper chart, some is housed in the electronic chart. Merging those two has been a great challenge, and it sounds like it will be simple, but it's not. So supporting the infrastructure on how they want to go about this is critical. And for our clinics that serve at-risk populations, serve folks with very complex needs, it is a challenge to be able to be compliant in a way that the regulators want us to be. Because our goal is serving the patient with health care that's meaningful to them.
I'm Al McFarlane. You're listening to Conversations with Al McFarlane. We're talking about health care, in particular pay for performance. And we're going to take a break, listen to Wayne McFarlane and Jazz, and come back and explore the question. We have an audience here too, and we want, if you in the audience want to raise a question of the panelist here or the panelists who are joining us by teleconference, to step to the microphone and we'll have a conversation. I'm Al McFarlane. This is Wayne McFarlane.